Ahmed glaucoma valve implantation, no financial interest. I will go through this point from basic to this is the more important, the surgical point. We know this is said in Arabic, dirham وقاية خير من قنطار علاج. An ounce of prevention is better than a pound of care. For that is better when you mastering anything, you improve your result and you minimize post-operative complication. Let us start point by point. Patient selection, here this is the indication. The first is severe uncontrolled glaucoma who have failed previous glaucoma surgery. We know here from this is for Pervit, not for Ahmad, but this is also can we apply for Ahmad with less successful rate. This is over many years, the successful rate is very good as uncontrolled glaucoma surgery. Also, for any cases when we expected failure for trabeculectomy, and this is the more famous for neovascular glaucoma and uveitis glaucoma. This is another condition, is congenital and development glaucoma. This is not our first choice. Trabeculectomy, our first choice, but some cases, look, these cases is cornea de Lange syndrome, all malformation, even this is no bone here, and this is many high risk pulmonary and artery, any risk. I cannot go for the surgery many times. For that is given, this is no choice for anesthesia. One times go inside. For that, I the first time go directly. I didn't go for trabeculectomy, any risk for surgery. I go directly for AGV at both eyes and look here the eyes, how much is quiet after the surgery. This is not my first choice, but in this case it was the first choice. There is another indication as traumatic aphakia, pseudophakia, and also there is indication as the first operation. This is also not our first choice, but if we see in the BTVT study, they started with good result, but less than a trabeculectomy. Also, this is here the treatment result. Should be careful. This is here BTVT study, but we avoid this as first choice because the risk on the endothelial cell account. The site of the implantation is the best site is the superior temporal because more easy to implant the blade and less likely to distribute the ocular motility. Another choice, superior nasal, that's the second, but be careful for brown superior oblique tendon syndrome. Inferior position, there is limitation in the movement, but this is our choice where there is silicone oil. Now we started with the most important, this is the surgical part. AGV blood and anchorage and the tube fixation. This is very important, usually always to fixate your tube to the blade. Here with two unabsorbable suture and should be the node is embedded, this is during the thickness. This is my way. Always make sliding suture. One and with the Prolene, make sliding. You fixated the tube 100%. And this is the best way because you didn't have a chance to move your hand. Especially I make 10 to 12 millimeter posteriorly and the result is better. When you make with this way, you can fixate in your AGV, the blade 100% over the sclera without any movement. This is one trick. Second, this is, oh, sorry. Also, fixating the tube, because sometimes if any movement, one patient with me move that plate and move something foreign here, wake or move with the hand. If you fixate it with two suture here, 100% you didn't shifting the movement for the blade to the anterior chamber, or you have another security part in your operation to avoid this. Is I make usually two, can you make one? No problem. This. Now, look at these cases. This case is a child operated, this is as 15-year-old, operated. I see when they see, said that, yeah, this is the surgeon make this is a tube longer. When make rubbing the tube here with the iris, he make triming. This is logic. But don't decide that before you ask your patient to look to the side for the AGV implantation. Look, when he look to the side, the blade is not fixating on the tube, go and out and make rubbing with the iris. And this is the reason for the complaint of the patient. For that is very important to fixate. Priming the valve implant. Priming is very important to ensure that the valve blade are not fused during the sterilization of the technique. And this is for that very important to try the priming and see this is the aqueous is go this stream on point after point. This is very important and don't avoid this step. If you avoid, see this case. When I make the priming, this is the first AGV. Look, this side and this side. Expected, this is will not working at least. I sometimes make maneuver here and working. But when come from two sides, it will not working. I through and give another one. Look in the same situation for that same patient. For that, very important to keep at least two in your OT. So when I touch here, is working this AGV. Now, let me see what the first one. I finish the operation, I go to the first one. Why is not working at all? See here, I try my again. This is now I finish my operation. I try to keep away the leaflet. Still is not working. I open, please. Now when I go through and open, it's working. See now that the reason here. Look, when I open, this is the leaflet sticked on the tube. For that, this come the water from two sides. This tube will not working at all. Should through from the beginning. This is very important. Cutting the AGV tube. When you're cutting, especially if you're not expertise, cut longer. And try, even this is implanted in the anterior chamber, and see if this is the longer than that you need, can you cut again? It's more easy than you cut short and after that said, yeah, maybe this go down is enough or not. Cut longer and after that implanted. Tube insertion. This is very important to make gonioscopy before the surgery. If you find pseudophakic with peripheral antennosynekia, implanted in the sulcus and inferior, see this BKB is more less risky for the endothelium. And when you implanted here, because here the distance than what you expected. You find this is good distance, but when you see, no, it's longer. Then I remove again on cutting. You see this is short. No, because the direction is different now. Is you find is the long is very suitable. This is another trick in these cases. For reinsertion for the AGV, when you implanted the tube, see that now I go through, it's superficial, but I implanted that now the tube, I implanted the tube, find the tube is near the cornea. Don't wait, near the cornea, very easy. Remove and insert it again in another place. Make another tunnel, see if that is suitable on distance from the cornea, and can you close the first one? Is no harm during the surgery. If you keep in the first one, you lost the endothelial cell account. Cover AGV tube. The covering, usually we cover with the tutoblast, episclera. Usually I have one method when I have cornea transplantation. I prepare from the sclera with my hand because in Syria it's very expensive to do that. But now in Oman I have tutoblast. I implant it. But if I have thick sclera as the cases I presented today, I make that partial thickness and through the antennal sclera. See here these cases. I make a flap here, and I cutting the flap, and I modify after this is from the bed, thickness from the bed, go posteriorly here, but be careful this is not to damage the tube, and open this is over the crescent, and make tunnel, and inserted the tube during the tunnel, and kept covering all the tube as a part from the eye, and covering very well. And this on you now is finding this is here covering very well, and this is fixating. This is was a special cases today for malignant glaucoma. For that I make ligation posteriorly. See this is the tube as a part from the eye. Now the last is before the last one, tenon cyst AGV implantation. We know this is an AGV more than other 3 to 6 weeks in 32, 82 cases of from the cases as the capsule around the blade. And can be treated medically, and this is for that is approved of the study to use tumolol and the dorzolamide combination with the pressure more than 10, 11 after the AGV implantation to avoid and decrease the risk of encapsulation. This is another way. Can you use for needling? I not advise anyone to do or remove the capsule. I see you now. Surgical excision for the blade. See this video. This is here for AGD de-roofing. Said always de-roofing. De-roofing is not working in most cases. See now what the reason here. Look, I make inject here one because if you open on the IC is working, this will damage the endothelium. I make viscous in the endothelium. Look here, open how much is the capsule. Look, see here, please. Now, how is the tenon invented in the blade. See, look, this is very strongly. I try to keep away. Now, after this step, don't be, I am in the safe side. Should this thing from the paracentesis, inject now, look, it's still not working. Now, look the problem. Is this another side that is invented from the other side, the phenol capsule? On this tube, be sure that 100% it will not working with you at all, and should be removed to save time. I removed and I closed and implanted another one on the other side. On the last part, because this is, I think it's 1 minute before the time, using mitomycin, as my colleague today, it's randomized controlled trial is no benefit, but usually I use, not always, but if you want to use, my trick here, I advise to use the LASIK Wexel, because no fiber fill this on complete Wexel, saturated with the mitomycin, on can you insert behind, and you are safe, it's no particle kept behind you, and after that you can washing. As a take-home message from my presentation, select your patient carefully. This is here, superior temporal is the best. Encourage your AGV blade tightly to the sclera. I advise you for the sliding suture. AGV priming is mandatory. Keep more than one AGV in your OT. Cut the tube, and after that, and the priming, insert the tube in the sulcus in pseudophakic if you can, especially if you have peripheral anterior synechiae. Change the tube site during the surgery. If you find that this is near the cornea, cover your tube. Don't say this is the tenon is thick. Don't use that. Do AGV priming after surgery excision for the tenon capsule if you want to make deroofing for the AGV. At the last, use a large Wexel sponge soaked in solution of mitomycin if you want to apply mitomycin, and thank you.
Thank you. So now I call Dr. Khalid Mahmood for his presentation on Ahmad glaucoma valve implant in atypical glaucoma. Is he here? So we move on to next speaker, Dr. Omer Kidwai on Paul glaucoma implant.
So does this mean I get double timing? Is it? No. Okay, Bismillah ar-Rahman ar-Rahim. Good afternoon again. Thank you so much, Dr. Ali. It was amazing. I'm going to learn that single knot technique from you. That's really important. Very useful. Thank you so much. Jazakallah. So we're going to talk about glaucoma implant. Okay, so we'll go through about the implant. I'm going to show you a few videos. But before we do that, we have to think about the fact that there are lots of options you have, including trabeculectomy and so on and so forth. Not every option works on every patient. There are patients that one option would work better than the other, okay? And that's where you need to know about the other things that's available. So that's just a small introduction of mine. As I said, before we go into the detail of what Paul glaucoma implant is, we need to know what options we have. At the moment, this is what globally is available for you, okay? What we have in Pakistan or underdeveloped nations, that's another story. But what we have, if we want to do a filtration or bleb forming procedure, which is more of a moderate or advanced glaucoma, irrespective primary or secondary, then we have trabeculectomy as a gold standard procedure. And you know, this is still, you know, running ahead of everything else, much cheaper. But the problem is, by principle, we need a controlled seepage of aqueous, not a flow of aqueous, okay? And as a human being, that's not possible. Some surgeons might be the best trap surgeons in the world, but not every surgeon is the best surgeon. We want things that should work in most of the population, I mean doctors' hands, rather than just a special one or two surgeons. So unfortunately, we have problems with trabeculectomy. And if you look at the literature, it varies from 47 to 90% success rate. Especially in secondary glaucomas, the success rate goes down a lot. I said this in the morning as well. We have to look for 4 tiers of hindrance. Number one is the sclerotomy, and then the flap, and then the bleb reconstruction, and lastly is the venous outflow. But all these three things fibrose very quickly in secondary open-angle glaucomas, and that's why trabeculectomy has much lower success rate. So then they introduce all these fancy devices. Gel implant, Zen Initial 45 had very bad results. Lots of surgeons have stopped using it. But Zen 65 is a new device launched about 2 to 3 years ago. A lot of data need to come, but it's showing promising results. And it's just a very quick insertion in the cataract surgery. You just go with an insert in the trabecular meshwork. It comes out on the subconjunctival area, just 2-3 minutes thing, and it forms a bleb nicely like a trabeculectomy. But it's very expensive, about £1,000 each. And then PreserFlow microshunt is the new trabeculectomy these days. In the areas where it's available, most of the surgeons are preferring PreserFlow microshunt over trabeculectomy because you get a controlled flow through it, okay? And less chances of less need of intervention. There has been studies coming up, PreserFlow trabeculectomy head-to-head comparison, and they've shown that the most important thing is the less need of intervention afterwards. Then we come to the glaucoma drainage devices. We know that Ahmed glaucoma valve is one of the long-lasting and very favorite device for lots of people. But the only problem that stops us from using it, it's the success rate. And we know Ahmed and Barwell glaucoma devices, comparative study have shown that the Ahmed has got about 70% success. In 30% cases, it still fails. And we have to remember that in secondary open-angle glaucoma, the failure rate might be much different. So this is where we get stuck. And that's why people like to try the tubes. So again, you have to select the patient. If you are looking at a patient's pressure of 50, and if it comes down to 25 or 20 with a single drop or maybe a couple of drops with Ahmed, then Ahmed not a bad option for him. But if someone's got a pressure of 22, 23 on maximum treatment, and you have to bring the pressure down to 10, 11, then Ahmed is not the ideal choice for them. And then you need to look for the tubes. So Barwell has been in the market for long run, but the problem with Barwell is that very high risk of hypotony because it's such a thick bore tube and can lead to hypotony if you don't put ligature sutures properly. But you need a good device for secondary open-angle glaucoma, which is cheaper, better success rate, and low risk of hypotony. So the PreserFlow is now leading the way because it introduced the concept of smaller lumen, and those two devices have the similar lumen. So Paul came up with this idea, which was mainly mutually formed by the Moorfield High Hospital consultant Keith Barton and Paul in Singapore, and basically based in Singapore. And they devised a much narrower tube, and they took good points from every tube. So they took the larger plate, which is one of the reasons of success with Barwell, and less encapsulation. They took that, and they also took this small well technique, which was taken from Moltano. So they took lots of good stuff from different things, and they made this new tube. So if you look at the video, you can see that this is the PreserFlow microshunt, and the lumen size is comparable. Barwell is much thicker than that, and that's why more risk of hypotony. So much less risk of hypotony, but favors of Barwell. So you can see that Barwell's lumen is really thick. That's PreserFlow and Paul, much comparable. So in between the two. Cost is much less than a PreserFlow. PreserFlow is £1,000, and Paul tube is 300 pounds. So that's a big difference. You need to put ripcord stitch like you do in Barwell, much thinner ripcord. And ripcord gives you an extra edge that if your tube is failing, you can take it off very easily on your slit lamp, which is not the case in Ahmed glaucoma valve. And this is the small well I was talking about. So you can see the flow when you've implanted it, okay? And if you see a no flow, then you can pull the ripcord a little bit more. And if you see a lot of fluid, you can push the ripcord a bit more. So longer the ripcord, the more hindrance it provides, less flow. And if there isn't enough flowing, then you can pull the ripcord a little bit more, and then you have a little ripcord left, and there will be a bit of flow. And if it's still flow, you can put a ligator suture on. Now, this is one of the techniques of Paul tube implantation. This is the ideal way of doing it when you've got everything available. As Dr. Ali said, Tutoplast. I love Tutoplast because that lasts longer. You can do all these surgeries under local anesthesia if you want to, but ideally GA. We have done cases on subtenon, and it worked very well. Patient was absolutely painless during the surgery, but I would still prefer under GA most of the time, because these are secondary glaucomas. You might require a bit of longer duration for that, so better to have them fully sedated. Sorry, all these steps are pretty much the same as you do for any GDD, but I like to put lots of MMC. This is what I emphasize in the morning as well. There has been an argument, lots of people are not putting MMCs with GDDs, but trust me, they work. They make your outcome totally different. And don't be scared of mitomycin C, it's your friend. We argue those leaking blebs, leaking cystic blebs, and blame that to mitomycin C only, but that's your surgical technique that matters more rather than the mitomycin C. So here comes the Paul glaucoma implant. So you can see that it's pretty much the same size as slightly shorter than Barwilt. It's the exact distance is almost the distance between two recti. So you don't necessarily need to identify the recti. You can still tuck it in, but better to identify the recti. And then you just put the rib coordinates, 6-oproline, that's it. And this will be tucked in under the subconjunctival space. And maybe 6 months later, if you see if the pressure is creeping up a bit, you can pull it out and pressure comes down nicely, like a releasing suture trabeculectomy. So not much of an effort like you have to put on Barwilt, where you have to tuck it in both the ends inside, otherwise it doesn't fit in. And the suturing place is quite anteriorly located, so you can easily tuck it in. I think I'm running short, so I'll just move on quickly. So after this, we put the tutoplast, which is absolutely necessary. And lots of people are just doing the flaps in the beginning and put the tube in. I would definitely discourage that. You need to cover the tube all the way to the plate as much as you can, because this will erode at some point. So that's the tutoplast, and we place that. Now this is how we do it in Pakistan. So as he showed his video on Syria, we make either I make 2 tunnels and a flap, or 1 tunnel and a flap, depending on the space that I have. You have to create a partial thickness scleral flap, so these tubes can easily pass through it. It's not working. This is not counted, is it? So you create a flap. Normally, I like to put the tube in front of the iris in the anterior chamber, and Paul gives you more edge in the shallower ACs because the tube size is much narrower. So when you enter into the AC with AGV, you enter with 23 gauge needle. With Paul, you can enter with 26 or 25 gauge needle. So much thinner, much thinner. And if you put them in AC, you will see the difference, how thin a Paul tube is. So less chances of endothelial erosion, less chances of conjunctival or scleral flap erosion if you put that, because it's much thinner tube. So lots of advantages in terms of that. Again, Ijari. Okay. This is again, just wanted to show you one quick thing, which is I've tried all sort of MMC insertions, but recently I'm loving this technique. Ike Ahmad, which is like a guru of ophthalmology, used to do it for ages, but I was too scared to try it. But for last many attempts, I've been doing it successfully. Very nice. It saves you 3 minutes of soaking it with sponge, and doesn't cause any problem at all. It just seizes very nicely. Not much data is coming up. This tube was launched about 5-6 years ago, but the maximum data has been published so far is 4 years. And so far, it's been very good. Comparable in terms of the outcome, just parallel to the Barwilt. Slightly lower than Barwilt in terms of success, but not as much as Ahmad, but much higher than Ahmad. And and much easier than rest of the things. So at the moment, it's head-to-head comparison with Paul and Ahmad ClearPath all over the world. As I said in the beginning, in UK and Europe, they love Paul tube, but in North America, they love Ahmad ClearPath because of easy insertion. Thank you so much, everyone. And
Thank you, Umair.
yeah.
So our next presenter is Dr. Aisha Shakil. Her topic is Barwilt glaucoma drainage device implant.
Assalamu alaikum, everyone. So thank you very much, Umair and Dr. Ali, for such nice video presentations on 2 of the glaucoma drainage devices. So I'm going to talk about another glaucoma drainage device, which is the Barwilt tube implant. So I have no financial interest in the devices which I'm going to discuss in this presentation. So glaucoma drainage implant is basically a silicone tube, which basically shunts aqueous humor from anterior chamber and posterior chamber into a subtenon space near the equator where the plate of the tube is generally secured. The advantage of using a glaucoma drainage implant on a conventional trabeculectomy is that it's a permanent sclerostomy, and therefore, it cannot close down or scar down like a traditional trabeculectomy. The other advantage of using a glaucoma implant is that it basically shunts the aqueous humor towards the equator, where it is considered that fibroblasts are less active. So the most common indication for inserting a glaucoma drainage device is a failed mitomycin C augmented trabeculectomy, but there are other indications as well. So basically, should we be using glaucoma drainage devices more early, in patients who are refractory to maximum medical treatment? So for that, there was a randomized control trial, which is called the TRAB versus trabeculectomy study, which basically compared Barwell tube and trabeculectomy head-to-head. And it concluded that in about 5 years' time, patients who had Barwell tube implant, basically they did well compared to patients who had mitomycin C augmented trabeculectomy. So the glaucoma drainage devices, they come in all different shapes, sizes, materials, and their presence or absence of valve in them. So currently we have how do you go back? Yeah, sorry. So currently we have a non-valve device, which is the Ahmed glaucoma valve, and it's, I think, the most commonly used one in Pakistan. But we have the non-valve device, which are Maltino, Barwell's, the Paul glaucoma implant, and the Ahmed Clear Path. So you just saw Ahmed valve and Paul glaucoma implant. I'm going to now discuss the Barwell implant. So should we be using shunts earlier? Yes, TVT study definitely recommends that. But which shunt we should be using? So for that, we have 2 trials which compared Ahmed valve with Barwell valve, and they are ABC study, Ahmed Barwell comparison trial, and Ahmed versus Barwell study, or AVB study. And basically both the studies, they compared the 2 valves head to head, and they finally found out that in the end, Barwell tube is slightly superior to Ahmed valve in the long-term control of intraocular pressure, but Barwell tube has more chances of complication which are related to hypotony. So for all the cases in which we have conditions with low aqueous production rate, like uveitic glaucoma, neovascular glaucoma, or patients with previous cyclodiode procedures, we can use Ahmed valve. Sorry. So we can use Ahmed valve for all the low aqueous production procedures, but in the rest of the cases we can use Barwell tube. So now I'm going to describe step-by-step surgical technique of insertion of the Barwell tube. The first step is planning, as Dr. Sheikh very nicely mentioned, that we need to plan where we are placing the tube inside the eye, and also where we want to, suture the plate on the surface of the eye. So generally, we usually, select supratemporal quadrant for placing the implants. We can mark the cornea, and that helps in, at the time of surgery, it helps in identifying the area where we want to place the tube and the plate. Generally, we mark the 12 o'clock, 9 o'clock, or 3 o'clock position before the surgery. Corneal traction sutures are used for exposure of, making the area more exposed so that we can do a good dissection. And generally, we use a 7-0 silk on a cutting needle to use the traction. So this is the video of the first Barwell tube implant that we implanted in Pakistan in 2019. So it's going to, Yeah, so this is the corneal traction suture, which we are placing on the cornea to expose the supratemporal quadrant. Here I'm using 7-0 Vicryl instead of silk. So we have exposed the supratemporal area. Then I inject lignocaine to lift the conjunctiva, and the peritomy is done to expose a large area of the supratemporal quadrant and the sclera, because it's a large tube. 2 relaxing incisions should be given to expose the area. It makes the life easy. So this is the relaxing incision being given, and the other relaxing incision as well. So generally a fornix space flap of the conjunctiva is made. Now we apply mitomycin C for about 3 minutes, 0.4%, in the area where the plate will be placed, and then the recti muscle are isolated because it's a big tube. It has to be inserted underneath the superior and the lateral rectus muscle. So we need to identify the recti muscle. So superior rectus muscle is identified, and now the lateral rectus muscle is being identified. This is the plate of the tube. Now just observe this blue thread, and this is that ripcord thread which Dr. Umair just mentioned. So basically, because it's a non-valve device, we need to close the tube so that it starts to function at around 6 weeks' time, when the capsule around the plate is developed. So we don't want the tube to function till 6 weeks. So we close everything. We close the lumen. We close it from outside as well. So this is the stent suture which is there. Then we place the tube underneath the recti muscle, and then we suture it 10 millimeters from the limbus, from the 2 holes which is there in the plate. So I've just improvised the straight needle. We curved it because in Pakistan we didn't have 9-0 Prolene on a spatulated needle. So I improvised, curved the needle myself, so stitched it on the sclera. So we have to tightly stitch it on the sclera. We don't want the tube to move with the movement of the eye, because that can lead to erosion later on. So the second improvisation was to make a scleral flap, because we didn't have access to tutoplast or cornea or any sclerocorneal button. So we made a 6x6 scleral flap, partial thickness scleral flap, and then we'll insert the tube from underneath the flap. So the tube is then shortened. You can still see the Prolene suture within the tube, the blue thing, which is the stent suture. So a tract is made with 25 gauge needle, and then the tube is inserted into the anterior chamber as far close to the iris as possible, away from the cornea. Then the sclera is stitched on top of it. Before stitching the sclera on top of it, we need to secure the tube with the Prolene, 9-0 Prolene or 8-0 Prolene, and then we close the scleral flap. The second flow control mechanism is this ligature suture. So I'm tying 6-0 Vicryl around the tube to close the tube completely. So that is the second flow control mechanism that we use in Barwell to prevent post-operative hypotony. So then the ripcord suture was also, the end of it was stitched on the side of the eye, and then conjunctiva was, closed on top of it, so that later on, if we need to remove the ripcord suture at 6 weeks, we can, expose the conjunctiva from here and then just pull the stent suture later on. Okay, so because Barwell has high complication rate related to hypotony, we have 2 flow control mechanisms that we can do in Barwell tube to prevent those complications. So the first one is that, the stenting suture or the ripcord suture, as Dr. Umair mentioned. So what we use in Barwell has a bigger lumen, so we use a 3-0 Prolene suture here in Pakistan because we didn't have Supramid. So we stented it with that, so we close the lumen. That prevents the early post-operative hypotony. It can be removed after 6 weeks when we think that the capsule is formed around the plate. The second flow control mechanism is basically the ligature suture. That is, from outside the tube, we close the tube from outside. So we can use either an absorbable 6-0 or Vicryl, which gets absorbed on its own in about 4 weeks' time. But if we are not using that, then we can also use 10-0 nylon suture to close the lumen from outside. So this is a ligature suture around the tube. So if we are using a non-absorbable suture, then we need argon laser suture lysis at around 4 weeks' time to start the tube functioning. If we are using non-absorbable, then it needs to be removed. So post-operatively, what we do is, because we have closed the tube completely for the first 6 weeks, we do not stop anti-glaucoma medicines. So we keep the patient on their pre-operative anti-glaucoma medications, and we start them on steroids and antibiotics like in any eye surgery. So post-operatively, there are 3 scenarios. So if the patient has got a normal pressure, then we do nothing. That is an ideal thing. We are happy. And we keep the patient on these drops for about 4 to 6 weeks' time, and then we taper them off gradually. And then we when the tube starts to function, then we start to remove the sutures. But if the pressure is high, which is very common in Barwell tube in the early post-operative period, then what we need to do is, then we need to follow the patient weekly, and we need to keep on adding the anti-glaucoma drops. So if the patient is on maximum anti-glaucoma therapy, then we add oral acetazolamides or oral Diamox. So we keep them on maximum tolerated anti-glaucoma therapy at around 4 weeks' time. So at around 4 weeks' time, we go for the removal of the ligature suture. If it's not an absorbable suture that we have used, then we can go for argon laser suture lysis at around 4 weeks' time. If still our pressure doesn't go down with this intervention, then the second thing that we can do at 6 weeks' time is to remove the stent suture or that ripcord suture after exposing the the suture where we have stitched it at the time of surgery. So the third scenario can be, it's the most dreaded one, and this is the one which produces a lot of complication in Barwell tube, and that is hypotony. So on the first post-op day or in the first week of surgery, if the patient has got low intraocular pressure, then we need to look at the anterior chamber. So if the anterior chamber is formed and there are no other complications, then we just observe. We do nothing. But if there is maculopathy or effusion, then we can think of injecting Helon in the anterior chamber. The other scenario is that right from the beginning, the AC is shallow. It's not flat, but it is shallow. So if it is shallow and there are no other complications, again, we can observe. But if there are maculopathy or effusion, then we need to inject Helon in the anterior chamber, and we need to bring the pressure up by injecting Helon. The third thing is, if the anterior chamber is right away, right from day one, there's hypotony and it's a flat AC, then there's probably a leak. Our flow control mechanisms that we use, they didn't work, so we need to take the patient back to theater and we need to do a tube tie. So in the end, I would like to conclude by saying that generally they are safe devices now, and they can be used as a primary treatment. The flow control mechanisms that we use in Barwell, they work well. Ahmed valve is relatively safe for patients with low aqueous production rate. With this, I would like to conclude my presentation, and with permission, I would like to take the questions now as well, because I'm leaving for Islamabad, so I'll not be here in the end. So if you have any comments or questions, you can ask now. Yeah. So the problem here, yes. So we inserted very few here in Pakistan. The reason is their continuous supply. So the ones that we did, they are doing very well. I presented in the Caroft in August the result of my first the patient. So he's doing very well. His pressure is running in around 12 and 10. Without any drops. And in his case, we didn't have to remove the stent suture as well. So just the ligature suture got absorbed, and at 4 weeks' time, his pressure came down to 10 and 12 without the the removal of that. So it works well here in Pakistan. The problem is its supply, availability and supply, which it costs around $600. So it's pretty expensive, and that's another problem. But yes. So that is why trabeculectomy is still the gold standard here in Pakistan. Lot of heartache. Lot of interventions required post-operatively, which again in our setup to explain that to a patient is a bit tricky, because you have to take him sometimes back to theater to remove the stitches and all that. So patients are generally not happy. We are happy because the pressure is in control. Yes, okay. We can use that. Okay. Is reduced. Yeah. Okay. Yeah. Okay. Any other comments or questions? Thank you very much.
Thank you, Dr. Aisha. So next presenter is Dr. Nasir Saeed, and his topic is results and complications of AGV implant in Pakistani population.
Rahim. Assalamu alaikum. So my today's topic is Ahmad glaucoma valve implant results and complications in Pakistani population. We know that at present the only treatment for glaucoma is reduction of intraocular pressure, and we usually adopt surgery. Recommendation guidelines are that first we go for medical treatment, and when the maximum medical treatment fails, then we go for a glaucoma surgery. At present, the golden choice is trabeculectomy. But as we know that there are a lot of problems associated with trabeculectomy, and we know that sometimes there are indications, there are high-risk patients which are going to fail after trabeculectomy surgery because of high risk of scarring. The bone healing problem, we had a very nice lecture of Dr. Rashid Ziad in the morning, but still we don't have a perfect control of wound healing. The next in line of filtration surgery is a drainage device, and probably it might be able to control intraocular pressure in a much better way. As earlier discussed, there are many types of glaucoma drainage devices, and at present the indications are those cases which are at high risk for failure. But the TVT study now, the indications are more widening, and there are much more cases, even those which are not for high risk of scarring. The glaucoma devices gives a better result. We know there are two types, valved and not valved, and Ahmad glaucoma valve is one of them. The glaucoma valves, the glaucoma drainage devices, there are meta-analysis, and the medical data show that for the previous few years there is higher use of glaucoma drainage devices. Based upon a systemic review of the published data, a panel of glaucoma specialists concluded that low IOP levels cannot be attained with glaucoma-driven devices as compared to the trabeculectomy. Rate of failures of glaucoma drainage devices averages about 10% per year, and GDD seem to have benefits, IOP control, duration of control comparable with those of the trabeculectomy in the management of complex glaucoma like phakic or other glaucomas. And level 1 evidence indicates that there are no advantages to the adjunctive use of the antifibrotic agents or systemic corticosteroids with currently available stent, although many people still use, but there is no livable evidence for that. 5 years follow-up of TVT study concludes that tube shunt had a higher success rate compared to trabeculectomy with MMC during the first 5 years of follow-up. Both procedures were associated with similar IOP reduction and use of supplemental medical therapy. IOP was 14.4 plus minus 6.9 millimeter of mercury with tube as compared to 12.6 plus minus 5.9 millimeter mercury in trab with MMC. The cumulative probability of failure was 29.8% in the tube group as compared to 46.9% in trab group. The rate of reoperation for glaucoma was 9% in the tube group and 29% in the trab group. Although this study was not a generalized study and it was more based on bevel, but the results to some extent can be generalized. The ABC study, a multi-center RCT trial comparing the efficacy of AGV and bevel, shows a low IOP with bevel and a lower complications rate of AGV. In a Cochrane review of glaucoma implants, Meiker et al. Concluded in a meta-analysis that no specific aqueous shunt stands out as clearly clinically superior with regard to either safety or efficacy. So they are at present much comparable, and one cannot say that which one is the fast superior. My studies on Ahmad glaucoma wall, and the reason for that is that its availability in Pakistan, and we think that it is more safe. Everybody know that in initial stages of surgery, and it doesn't need multiple surgeries. That is another advantage as compared to a bevel implant. And we know that clinical efficacy of AGV has been reported from almost 98% at 12 months. There are different complications reported like hypotony or flattened chamber, choroidal hemorrhages, suprachoroidal hemorrhage, vitreous hemorrhage, uveitis, etc. And retinal detachment, no. Corneal decompensation is one of the problems, even if it doesn't touch the cornea. In our study, we analyzed the results of our cases which were performed between 2005 and 2019, almost 15 years study. And only those cases were included which had at least 12 months of follow-up and data. So in fact, we did more cases, but the included cases are number of cases are less. The body of implant, this was material, the method, the body of implant was sutured to the sclera superior temporally most of the time, or superior nasally at least 10 millimeter from the limbus. Prolene 7/0, 6/0 or 10/0 nylon suture was used for fixation in different cases. Half thickness scleral flap of 4 into 6 millimeter size was created to cover the tube which was inserted into the anterior chamber for 2 to 3 millimeter through a stab wound created by a 23 gauge needle. In some cases, scleral tunnel was created instead of fastening the flap to cover the tube with the sclera. In only 4 cases, preservative sclera was used to cover the tube, and the reason is number 1, availability, and number 2 is the cost. This is one case, a congenital glaucoma in which a primary tube was inserted. This is the method, the surgical technique. This is the tube and the plant. So we In this study, a total 138 patients are included. 73 were male and 65 were female. And a total number of 151 eyes, 64 right only, 61 left only, and 13 were bilateral. The cases operated were congenital infantile glaucoma in 48, aniridia, aphakic glaucoma, post-traumatic uveitic, new vascular, post-PPV, steroid-induced primary open-angle glaucoma, and penetrating keratoplasty. Before we initially we used more complicated surgery. We inserted the tube in more complicated cases, and you can see that the previous surgeries performed: one trab with an MMC in 21 cases, 2 trabs, 14, 3 trabs, and trab without MMC, combined phaco. 27 were taken as a primary procedure. Number of anti-glaucoma medications before AGV, no medicine 18 cases, and you can see the number of cases 2 medicine used by 54 patients. Result as the mean IOP before surgery was 27.76 millimeter of mercury with a deviation of 8.69 millimeter, minimum 22 and maximum 60. Mean IOP at last visit after surgery was 15.53 millimeter with a standard deviation of 6.8, minimum 10 and maximum 38. And we can see the p-value. And number of drugs were reduced to enormous level, 3 drugs in 12 patients. Still there are some patients needing medicine, 2 drugs for 25 and 1 drug in 22 patients. These were complications. We faced a very high rate of hypertensive phase, 105 cases, that is about 76% of cases we went through the hypertensive. Raised IP requiring medication in 59 cases, surgical interventions in different forms ranging from needling to replacement of valve, 54 cases, that is 1/3 of the cases. Encapsulation of the body of the implant in 14 cases where we have to remove the cocoon around the implant. Poorly controlled IOP in 9 cases where we have to revert to another surgery. Exposure of tube implant in 7 cases. Shallow AC in 5 cases, but these were non-significant. Migration of tube anteriorly or slightly posteriorly. Hyphema, only 4, retinal detachment, 4 cases and all of these were the ophthalmic eyes. Probably they had large eyes and they were exposed they have high risk for retinal detachment. Corneal tube touch in 3 cases, corneal edema without a tube touch. And 3 cases, we had to eviscerate 2 patients after suffering from endophthalmitis. And we suffered 1 expulsive hemorrhage during surgery. I skip. These are a few photographs of few cases. You can see. The cyst formation and needling, and this is a corneal tube touch causing corneal edema, another one with corneal touch, and this was a case of endophthalmitis. You can see the exposure of the tube with infection. Another case. So in conclusion, the AGV in our patients show favorable results looking at the condition of the eye which were saved. Most common complication was the hypertensive phase, which lasted from 6 weeks to 6 months, and patient continuously needed to be monitored. 10% of cases developed encapsulation of bleb, which implant bleb, which needed some sort of intervention. The role of glaucoma drainage device in the management of glaucoma is not yet clearly defined. There is need to develop better biocompatible material. There is a need to develop better designs, and there's need to develop better surgical techniques. So thank you very much for it.
Thank you, sir. So our next presenter is Dr. Anik Mirza, and his topic is results of Ahmed glaucoma valve for neovascular and under secondary glaucomas.
Bismillahirrahmanirrahim. Vision perceives him not, but he perceives all vision, and he is the subtle, the aware. Whenever we see a case like this with florid rubiosis, our usual response is to put that patient on anti-glaucoma drugs and then wait for the end result, unfortunately, and that is a painful blind eye. So this is something that needs to be understood, that we can do something about these cases. Studies have shown that about 30% of refractory glaucomas belong to neovascular group. And a refractory glaucoma is the one which responds poorly to topical anti-glaucoma therapy and surgical incisional glaucoma surgery. So wondering how would a neovascular glaucoma behave as compared to other secondary glaucomas. After Ahmed valve implantation, I decided to carry out a comparison between the two. All the cases in my study underwent implantation of Ahmed valve, model FP7, 8 to 10 millimeters behind the limbus in the supratemporal quadrant. This is the most favored quadrant. Cases of neovascular glaucoma were given intravitreal Avastin 5 to 7 days before surgery. Then post-op examinations were conducted at day 1, week 1, and then subsequently at month 1, 3, 6, 12, and then finally yearly for 5 years. But unfortunately, some of the cases belonging to neovascular group had, of course, they had ischemic heart disease or diabetes or other chronic illnesses leading to ischemia. So some of them were lost to follow-up because of early demise. So I restricted my comparison to 1 year because I had the cases follow-up till 1 year, the complete follow-up. Pre-op and post-op comparison was carried out vis-a-vis vision, IOP, and complications. The success criteria was defined according to the success criteria usually found in the literature for these cases, that is adequate IOP control, not requiring subsequent glaucoma surgery, not requiring subsequent tube removal, and no loss of light perception. A successful IOP outcome was defined as ranging between 5 to 21 millimeters mercury. If it was without topical medication, that was declared a complete success, and if it was with topical medication, then it was a qualified success. The demography was more or less similar between neovascular and other secondary glaucomas, except for the etiology. In neovascular glaucoma, the etiology was PDR and CRVO, as we used to believe that CRVO is more commonly causing neovascular, but today Dr. Mahmood Ali also mentioned, and I've also seen more of the cases with proliferative diabetic retinopathy, and then followed by CRVO causing neovascular glaucoma. Other secondary glaucomas, they had pseudophakia, previous TRABs, uveitis, or trauma as the cause of secondary glaucoma. Number of patients was 26 in neovascular and 28 patients in other groups. Age range was slightly more in neovascular group, as it is usually the case. It was 49 to 73 years. In other secondary glaucomas, it was 30 to 70 years. There was a male preponderance in both the groups. In a neovascular group, it was 20 males to 6 females. In other secondary glaucomas, 17 males to 11 females. The visual results showed marked improvement in vision in both the groups. And you can see here, it's all blue here. This is the improved vision, which looked very encouraging. Actually, it's even a single line improvement that means improvement for these eyes, which are already in advanced stage of the disease. So it's all blue here in both the groups, and look at the comparison between other secondary glaucomas and neovascular, almost near to 50% had some visual improvement. Stable vision was seen in this area around shown in yellow zone, and about a quarter of the cases had decreased vision shown in red. Then the IOP results, IOP showed improvement in almost all the cases. except one or two. In neovascular group, the mean pre-op IOP was 43.42, which decreased 1 year post-op to 15.88. So that is almost two-third fall in IOP even after 1 year. In the other secondary glaucomas, the pre-op IOP, mean IOP was 33.78, which decreased to 14.53 millimeters mercury. And the mean fall in IOP percentage between the two groups was not statistically significant. These are the IOP results. It's all blue here. This is the area with decreased IOP. And this red area shows stable IOP. In some cases, stable IOP meant an IOP within 3 millimeters mercury of the pre-op IOP. And a small number of cases with increased IOP post-operatively. The complications in neovascular group was, most common was, of course, hypertensive phase. As Dr. Nasir Saeed was also saying, most common thing is hypertensive. Usually it happened after 5 to 6 weeks and stayed for a few months. So 17 cases had hypertensive phase in neovascular group. Hyphema was seen in 4, tube cornea touch in 1, and cystic bleb in 1. In other secondary glaucomas, 18 cases had hypertensive phase, diplopia in 1, and combined diplopia and ptosis in 1. This diplopia was not because of tube plate impinging upon the muscle. It was because of a large cystic bleb, which after bleb needling and massage, gradually it subsided after a few months. Overall results were very encouraging, whether complete or qualified success. Failure was seen in only 2 cases, each in both the groups. And the good thing was complete resolution of rubiosis in all the cases. These are the overall results. This is complete success almost in 1/4 of the cases in both the groups. Qualified success seen in about 2/3 of the cases, here all red in both the groups. Quite similar results. And failure was seen in, this is shown in yellow color. In neovascular group, it was in 7.7%, and in other secondary glaucomas in 7.1%. So overall, my results after 1 year showed a success ranging between 92 to 93%. In other studies, we have seen a success ranging between 60 to 100% after 1 year, which is quite similar. One of the local studies in our population showed an IOP decrease from 41.58 to 13.77 1 year after surgery, which resembles the results seen in my study. Then earlier literature favored use of AGV in post-op secondary glaucomas, but now there is an increasing trend of using AGV in neovascular glaucomas. Still, some studies do not show promising results with AGV. This could be because of the racial differences. We know African Americans are known poor responders to topical therapy and incisional surgery, but in our population, the result was better. And the other thing is, neovascular glaucoma is not a one-time battle that we operate and everything is fine, not like cataract surgery. You have to manage the patient. There are multiple fronts, battles you have to fight after surgery to manage these cases. But if you do and you are persistent, then you can really save this segment of patients. Finally, I would conclude, the cases of secondary glaucoma not controlled with topical therapy carry a poor prognosis. Without aggressive surgical intervention, they are prone to complete visual loss. The most notorious among them is neovascular glaucoma. Amath glaucoma valve implantation is effective in saving useful vision and controlling IOP in majority of these cases. And the results are comparable between the two groups. Thank you very much.
Thank you, sir.
That was pre-op. That, yes, in some cases I had to give it afterwards as well. But pre-op, one VEGF did wonder. Because without that, there is very troublesome hyphema. Definitely, most of these cases have quite dense cataracts. They are old patients with all diabetes advanced and with cataract. But wherever I could see, and then we treated with PRP and then repeated Avastans, of course.
Thank you, sir. So our next presenter is Dr. Ali Zain, and his topic is efficacy of Zain glaucoma stent in cases of refractory and stage glaucoma.
Thank you very much. Thank you very much. I'm Dr. Ali and I'm Associate Professor of Ophthalmology in King Edward Medical University. I'm basically a VR surgeon, so don't expect so many questions as regarding the glaucoma. I'm basically a VR. Yes, please. Second. First slide. मैंने खुद यहाँ से control करनी है? Okay, basically the purpose to devise this kind of stent is that I'm being a VR surgeon, the most, the nightmare for us is the high intraocular pressures. Either it's because of secondary to oil injection, or it's because of new vascularization, new vascular glaucoma, or it is because of any, clogging of the trabecular meshwork post removal of the oil even. I mean, if you remove the oil, still the trabecular meshwork which is clogged up and the pressure is high, and still we are. And the third most important thing was the cost. I mean, I'm not convinced with Ahmed glaucoma valve. Most of the surgeons here, they are using valve surgeries, they're doing valve surgeries, but is it available commercially and is it easily available? The straightforward answer, to this question is no. It's not that easily available, it is not that cost effective as compared to our part of the population where we are mostly practicing in the government setup. So what we did was, supposedly, the very same thing that you just mentioned, that this is a new vascular patient which came to me. He had, excuse me. Again, this is a new vascular glaucoma patient. He had high intraocular pressure. Roughly, it was aging to 44, and even with mannitol and a tablet azidum, the pressure was not coming down. In another case, after surgery, the patient has already one episode of one episode of trabeculectomy. See, there was one trabeculectomy port which has been, he had already undergone trab. The patient has a retinal detachment surgery. We had his retinal detachment and then the oil and all the complication of oil related to that, which we were facing. High intraocular pressure was not coming back from 50. So what we did, what was the solution? Is obviously valves. Instead of going for the Ahmed glaucoma valve in our theater, what we decided that we should devise something so that the patient should be easily and readily available. So what we did was, yes, please, isko zara on kariega. Ye dusri hai, pehli lagana tha. Okay, yes. So this was the same patient with high intraocular pressure of 50, new vascularization and everything. After giving even one anti-VEGF, the pressure was still high. So we devised Zain glaucoma. I'll show you individually. It's a fenestrated tube. It has got two parts. One is the subtenon part and the other is the interior segment part. The interior segment part is going to be implanted in the very same way the way we used to implant the Ahmed glaucoma valve. We made a pocket, but it is so easy to implant. We just made a simple pocket between the two muscles and it is implanted inferiorly because most of them are for the refractive glaucomas and stage glaucoma, oil-filled eyes. So oil is obviously going to go up. So the thing which we are left with is the inferior drainage. So we normally put it in the inferior sac. We just make a simple, sac, cauterize the area just like the way we used to do with the trab. After cauterizing it, we are going to make a tunnel the way we used to scleral tunnel. And after making the scleral tunnel, this is the partial thickness scleral tunnel. We are going to fix the ZGS with the sclera. We are going to enter with the 15 degree. That is not an issue. This is the beveled edge, the same which we are going to implant the Ahmed glaucoma valve or the Beerwald valve. This is the very same way. But the next catch is, yes, next video, please. Next video, lagane. The subtenon part is going under the tenon. That's it. We are going to fix it. This is going into post-equatorial, into the subtenon space. No muscles need to be exposed. No muscles touch, nothing. We are going to fix it with nylon 10-0 right at the tip. See, hypotony has induced the bleeding from the new vessels present in the iris, and we are going to fix it. twice with a circulage through the implant, and once we are done, through the superficial scleral flap, we are going to one more bite, and we are going to secondary, superfix this implant so that it should not slip. Because earlier when we have started, the more basic thing was the slippage. We fix it, and that's it. The job done. That is going to hold. It will produce the initial hypotony which we actually desired. Because of the high pressure of 50 and all, we want to reduce it to 5.8, 5.8, and after even 3 to 4 months of follow-up, the pressure won't rise above 10. That because of the multiple fenestration in the subtenon end. If at all it had the blockage, we can even flush the interior part, and we can make it, yes, next, last piece. And even if it gets, next stage please. Even if it gets blocked, it can easily be flushed through the interior segment, and that will help it to make it more patent again, and will start working. We don't have to remove it again. And then we have to, because there was a case of neovascular glaucoma, so we had to post vein occlusion, so we have to clear the AC also, and that's it. The valve is in place, and the interior segment is formed, and the patient is happy and all, and his pressure is controlled post-operatively. Next slide, please. Yeah, and the second patient, I mean, these are multiple patients. We have implanted more than 45 of these patients. Initially, we do had this cases in which we have the drop. We were not able to fix it at the end, at the neck, bottleneck. So we devised the things. Yeah, isko on kare. That was the second case, which we initially which we had. And see, the bleb is formed and everything. The valve is in place. Oil is all cleared. The pressure is maintained. The vision is preserved. So that is to remain. That's it. Thank you. Next, go. Post-op results are fine. They are going good. It's well in place. It's the same. Now what we have done is that basically it's a tube which is about 10 millimeter, 14 millimeter in length. It has a diameter of about 0.2 millimeter from the interior end. Then it has a plate that is basically a foot plate. It's a small plate that is to anchor it from the edge. That's the AC part. Interior segment is going to go from here. That is a multiple fenestrated end and the smaller and the posterior end, and that is going to do the subtenon space. That is the one which we are going to do the trick of the drainage from the posterior end, and basically is formed at least 2 millimeter inside the AC. Yeah, sorry. 2 millimeter, and still it's ongoing studies. We have injected more than 45 or 48, and we are going to have a follow-up of these strands. So far what we have found out that it is very economically best to, in cases of refractory end stage glaucoma. Me being a surgeon, we receive a lot of high intraocular pressure. I mean, the only nightmare which we get is high intraocular pressure. Retina is all flat, is all fine, but pressure is not getting controlled, and the patient is losing vision. And if you have to go for AGV and all, even then it gets, after, there's a high success rate, but still, it gets, once it gets blocked, we actually have to do another surgery to remove all those, tenon cysts and all. So I practically find it very practical, easily to implant, and good post-op results. Any question, please? I'm open.
I think, hello, we are running short of time. So our last presenter is Alil Sheikh on our experience in micropulse CPC.
Good afternoon. Our experience in micropulse CBC. Micropulse available here in Pakistan. Yeah, available. Yeah, then this is our experience. I go through this many points. At first is what our option, you know, that is we always start with the drops to laser, trabeculotomy, glaucoma, and the traditional CBC. And you know, this is this gap in the last few years filled that is with the mix and micropulse CBC. And now that's from the mix make the MIPS to push the trabeculotomy slightly away. The micropulse is different from the traditional CBC. We know that traditional is one of the most form of cyclodestructive procedure, inhibits secretory activity of the ciliary epithelium, and typically reserved for the last on poor prognosis cases. And usually this was only for the blind eye with hypertensive eye because there is destructive here after the traditional CBC. For that is we look now, this is another technology, this is the micropulse. Micropulse here, this is the normal wave. Here this wave is showing the continuous wave beam in the as envelope for repetitive waves. This is in cycle 31.3. This is no destructive procedure, only a thermal effect, but unfortunately still is the mechanism is not totally understand. This is the problem. Here, this is with the laser. When this is apply the laser here, you find this is slow motion here in the ciliary body, and this effective. I don't know. If the video is working or not, this always the problem. Then see here that there is no any changes in the ciliary body before and after. This is compared to the traditional CBC. For that we know this is the difference between both. This is here destructive procedure. Only here this is a slightly inflammatory procedure with the thermal effect that make this is theoretically reduce the aqueous production, enhance uveoscleral production, and activate cellular biomechanical cascade. And this is a thermal effect on the ciliary body, not all destructive effect on the ciliary body. You know, this is the probe. This is all the probe. This is with notch here. This notch should be to the limbus, and this is to the eyelid. This is very important. But here, one trick when you use this probe during with the gel, you use the gel, you cannot see that the notch for well. And should be careful for that. I make the marker here to see this is during applying the laser. And now this is more easily with the bony air probe. This is the new one. But as the technology always from USA, they need the money. Was 90 minutes when the timer. Now this is only 30 minutes. Before we use, this is for many patients. Now only you can use for one patient. And should be this is here totally perpendicular to the sclera, is not parallel to the axis or not perpendicular to the axis. This is perpendicular to the sclera, is different from the G probe. And we make a sweeping with the micropulse here. And the power usually 2000. Now can you increase? But that is that advice from the company 80 to 90 seconds. Every hemisphere movement 10 to 15 seconds. Can you, if you need more effect, can you make to 20 seconds? Many of the European or Americans said this is with only local. Don't believe any local. But our patient in Middle East and this area of the world, you need retrobulbar and need IV sedation. And our peribulbar or GA. Topical is not working. Even this is courtesy from Dr. Sivitsky from Buffalo, who said that topical, said give, this is when during the laser make this cocktail. With this cocktail, if you give, can you give for your patient, can you make with topical? Because this is better than general sedation during this apply, take the effect for this laser. If you can give for the patient, you are on the safe side, don't be worried. This is the technology, this is the surgery. This is with the old probe, and this is with the new. Always I marker the 3 and 9 hour, because when you put a gel and move the eye is moving, sometimes rotate the eye with you, and you cannot know where is the 3-9 to avoid the artery ancillary here in this area. For that is better. Look here, this is the old is more bulky, big, and this is more easy, the movement, the bony air. Yeah, movement here, go hand here, and this is here, and this is usually in 15 to 20 seconds, 10 to 15. If you need more effect, can you make your hand motion more slowly to take more effect? The ideal parameter, this is here in this study only, this is can you calculate the power in joule, the power in watt, multiply with the treatment time, and with the 31.3 the cycle. If we said this is 2 and said this is 112 joule, that we may mean with apply 90 second up and 90 second down. And for that is when you see this table, the safe area is from 112 to 150. That means you apply 90 seconds up and down and to 120 seconds up and down. This is the more safe area. If you increase the power, you go to more to the risky, uncomplicated side. If you make less, you are go to the less effect for the laser. For that, it is concluded is this is more safer too in this area. This is the result is many randomized controlled pair is the same effect almost on the continuous wave, but with less complication. This is here the conclusion for this study. And this from my colleague Ahmed Abdurrahman from Egypt. This is also the same effect result, but the risk is with the hypotony is less than. And let me see also this is with the keratoplasty is safe procedure. Now we see this is our patient. This is here with us is from 2019 in Oman. And until 21, we make this is almost many cases. That's when we see this is the protocol. We don't go through the protocol. And this is the machine is for Iridex G6 probe. This is with the micropulse B3 micropulse the Mi B3. This is the old one until now, because it's new. And this year we started with the bony air. And we increased the power from 90 to 130 because all the cases with us that's operated only for the late stage. I don't need go for any cyclodisruptive procedure for early cases or for moderate cases. Here, therefore, that time you find this is 22. And this is here the follow-up is not important. But look here, this is here the failure criteria, additional procedure, severe complication, and all decrease IUP less than 20%. We consider this as failure. This is here the age. The female only 43. That means this is the always manner had more bad luck than the woman. Also the visual acuity is very bad because only go this is for advanced cases. We didn't go for early cases. If you see the optic nerve more than 0.8. On previous surgery in 25 patient of the patient was there is another surgery before. If you see here, this is secondary open angle glaucoma was most of our cases. But look here, neovascular glaucoma is also with high percentage. But micropulse is not working very well in micropulse. Should be take care about that. But also the bad thing is good thing because it's not good for neovascular glaucoma because working only for short time. But that sometimes you need because sometimes come patient with me with renal failure. I cannot give anything for him. And IOP 50 with seeing eye. This is very good solution. I make micropulse, give me 1 month to a month. The eye is totally quiet. I give the patient after that IGV. My colleague finish the laser, finish everything. The eye totally quiet. I go to AGV implantation or cataract surgery or cataract uncombined. But I have time to go for another procedure. But you consider this is the procedure for the end procedure is not good. This is here for most of our patient was pseudophakic because it's advanced. Look here, the effect is good. Effect is this from 35 with almost 4 medication to 21 with 2.5 medication. That you mean you didn't ask the patient to keep away from the medication. Also, the effect is only around 30% for the effect for decreasing the IOP and the medication. But this is good solution for advanced cases when you didn't have another solution to do. This is the advantage from this. If you look, this is here from 24 to 27 months and almost 26 months, the successful rate is still good. No rebound. Yeah, no, we got. Wait. This is here retreatment. Retreatment, you take this is very easy. In 14%, we need to retreat. And when we retreat, the successful rate only 54%. And this is, and on look here, we need that treatment in 2 to 15 months. This is early failure. But the rate of failure is 16%, according to the criteria that I say. 11I go to the glaucoma drainage device. As said, this is a neovascular glaucoma. Keep the eye quiet. And when the eye quiet, can you go for the surgery? One eye had the tube revision, and one eye is a trabeculectomy. We see cases, but look, the complication is very low. This is the advantage from micropulse cyclophotocoagulation. And look, 2.5 early hypotonic, choroidal detachment, 2 cases, persistent uveitis, 1 cases, and severe superficial punctate keratitis 3, and chronic pain. Also documented pupil dilatation, but I didn't face in my patient. Should be careful not to go to the iris route. Otherwise, you have pupil dilatation. Should be careful. Only I take one, I have many cases, but I give you only this option to see why I go to this surgery. This patient, 28, 20, 36, and 4 medication. Look here. There is lid notch, trichiasis, patient from many years, severe photophobia. Cannot open the eye at all. At all. You cannot open and see the eye, even measure the IOP. It is catastrophic to measure the IOP. I try this is, if you see this is aspersion eye, is very good for trabeculectomy and phakic eye. Even for AGV is not good. You cannot follow up this patient. For that, I have the chance. I go and make micropulse with slightly higher power, and see here this is until 3 months, and after that now more than 2 years with 2 medications the IOP control on the border. This is solution in these cases. This is only I use as instead of trabeculectomy because I cannot do that trabeculectomy. See these cases with Boston keratobrecedus and failed. This is good to go for AGV, but this is in these cases. If I have another solution to push the patient away, I go for this patient with micropulse and give me control to 9 months. After that, repeat the new medication and make another solution. After that, the patient end with the AGV at this eye. But this continue on the medication, uncontrolled on the anti-glaucoma medication. In this way, I use instead of traditional CBC because I need this is in the only seeing eye with Boston keratobrecedus. As a summary, micropulse is a safe and effective treatment for lowering IOP, and the number of the anti-glaucoma medication can also be considered as good alternative treatment option for patients after failed incisional glaucoma surgery, can avoid or postpone glaucoma surgery, and this is the good is repeatable. Can you repeat 1, 2? But I don't advise anyone to repeat more than, because I find that the third time is not working. I repeat it for 3 times, only one patient with ICE syndrome, and after that the patient willing to go and I implanted AGV because she refused 3 times, and her brother is doctor, refused, but yeah, but this is good, is not to lose the eye because it's 40, the IOP 40 for anti-glaucoma medication, and young patient, 35, with ICE syndrome, and refuse the surgery with 40 IOP and for anti-glaucoma medication. But the micropulse give me until understandable period, until the patient satisfied the surgery, 1 year. After that, I make the AGV implantation. I have that cases, but that's no time to present. This is advice also can titrate up. Can you increase the power or you are on the safe side? Is many patients I use 160 up and down, and you are on the safe side, not dangerous as mentioned from the company. Thank you.
comparative study currently
Yeah,
between 180 and 270 seconds.
yeah. This is good. And I think that's the result we found the same. Is there's not big difference.
Initially, the initial response and the rebound phenomenon, and it's almost back to square one. We published our results 1 year earlier, and we have had experience of this for the last 2.5 years now.
That's good.
And it is an interesting option
Yeah, this is only an option, but the problem now
for someone where you really can't operate at that time.
I don't know the price now, but was in Oman is 160 riyal, around more than $400 for the old probe. The old probe after that decreased $100 more, and for 90 minutes you use for sometimes we are 3 unit collected.
Was better.
Yeah, collected 5 patients and make the surgery is cost effective.
It's not working the way the older probe used to work.
Now it is not available from the company, only available the Bonnie Air, and this is only for 30 minutes. If you use the protocol in your OT as WHO, and should be asked the patient, and the assistant ask you and to go to the protocol of WHO, you can use for only 1 patient, maybe 2 eyes in the patient, but on the cost is also from the company go up, increase the price.
One probe on at least 10 patients.
But now, if you go to the protocol for the new probe, you cannot use for 10 patients. This is the problem.
That is the only way to reduce the cost.
Yeah, this is with the probe is for 30 minutes you cannot use. This is the problem. With the old probe, yeah, my colleague in Egypt used for 9 patients. With the 90 minutes is cost effective. But now with the 30 minutes, this is the problem. This is the timer when connected or make the first shot, the timer run. Thank you.
Making money.
Yeah, this is the USA technology.
Thank you, sir.
You got it?
Pediatrics, children.
I use for many cases for pediatric, especially with anterior dysgenesis. Anterior dysgenesis, I try when the patient need mostly anterior with totally opacified the anterior part of the eye with synechia. You cannot make trabeculotomy. You cannot make AGV because AGV will done with the BKB. At that time, is good solution to push the patient away from the surgery, but believe me, is not for a long time.
Can I answer this?
That's it.
I had actually, how did I started on this machine? I had a child who was 3 years old, congenital glaucoma. Both eye had congenital glaucoma, ophthalmos. One eye had detachment as well. That is when they
This-
came to me. And I had to do detachment surgery with foil because and the pressure never came down operatively from 40 to 50 millimeters of mercury. The other eye I did trabeculectomy with mitomycin C working beautifully. But this eye I cannot do anything for the time being. And that is what made me think I need another alternate and it works.
Yeah, this is.
These are the situations. Now that child is without oil and has the tube done. And
Yeah.
he's
Yeah, this is good when you have chance because I said this is not always is bad thing is bad for always. When something bad thing is not effective for a long time, but at least bad thing is the recurrence, and the recurrence here give you give you time to thinking on go to another procedure. This is I use now because said this is not good indication for neovascular glaucoma. Neovascular glaucoma, I think, can you move now the slow motion traditional CBC? Increase the time and decrease the power. This is good effective. Good effective more than micropulse and less side effect than the normal traditional 2 watt with 2000 millisecond. But if you didn't have, sometimes now, I didn't have always the traditional CBC, and always when the seeing eye, I am afraid from phthisis. I always try to keep away from any cyclodestructive procedure because the closed secretion, you cannot open again. Yeah, you cannot open again, but increase outflow anytime you can close. This is the issue, and this is the idea. Thank you.
Thank you.
Thank you.
So with this, we conclude this session. Do you want to have some comments?
No, I think this is here one. Go, that's Dr. Nasir. I think this is one from the study for the high risk for the high risk for. I think now with implantation, the AGV 10 to 12, when you have the distance to implant the AGV, 12 millimeter posteriorly, you have less encapsulation. Because this found documented the encapsulation in the capsule self, the tenon capsule, posteriorly is thinner than more anteriorly. For that, if you implanted 10 to 12 millimeter, you have better chance to avoid the encapsulation. And also, with the starting now, after the study of anti-timolol and this is production decrease, always my patient now, when the pressure, after the first week, if the pressure go more than 12 millimeter mercury, directly I started with timolol and dorzolamide, and the encapsulation really is less than before. But you need, don't say the patient you need this, I give no financial interest, Azarga or COSOP. I inform the patient you need this is 3 to 6 months. I don't inform this is you need 2 for 2 months. I inform 3 to 6 months, and when the patient come, sometimes find after 3 months, the pressure from 50, go to 12, 15, 18. After that, you find, come back 18, 15, 12. I decrease to timolol, and after that, remove the timolol. Depend on the situation, and you find this is, the risk is less. This is my comment. The hypertensive phase I have, I as I can posteriorly. For that, I use the sliding suture because the problem, all the surgeon try 6 to 8 millimeter because cannot tight. But even this is very shallow orbit, I cannot make the suture. I take the suture in this two side, but very posteriorly. After that, enter the AGV. Before entering, I got the suture through the hole, on push posteriorly, and make sliding. But be careful when make sliding, please. Will not lose.